Astăzi avem plăcerea să-l avem ca speaker pe profesorul Dănilă, care este profesor la Sloan Kettering, care, după cum știți, este meca oncologiei din Statele Unite. Profesorul Dănilă este specialist în cancer de prostată și el face cercetare de laborator în cancerul de prostată. Și astăzi o să ne prezinte aspectele esențiale legate de cancerul de prostată. Vă mulțumim că ați acceptat invitația noastră, domnul profesor, și puteți să începeți.
Mulțumesc, domnul profesor, mulțumesc pentru invitație. Bună dimineața din New York. Sunt Dănilă, am terminat Carol Davila în 96, după care am mers în Boston, m-am mutat pentru fellowship la Memorial Sloan Kettering în 2005 și sunt aici de atunci. Timpul trece repede când îți place. Mulțumesc, doar pentru invitație. Aș vrea să vorbesc despre cancerul de prostată, ceea ce fac în clinică și în cercetare. Aș vrea să vorbesc despre secvențializarea terapiilor în viața reală, în cancerul de prostată. În primul rând, scuzați-mă pentru Rom English dacă mai încurc româna cu engleza. Unele chestii nu se traduc ușor și înțeleg că este destul de curent să folosim. E greu să traduci mCRPC în românește. Am încercat, dar e foarte complicat. Acestea sunt conflictele potențiale cu fonduri pentru cercetare și consultant pentru diverse companii. Voi vorbi despre indicațiile de US FDA labels și multe dintre ele sunt folosite sau se pot folosi în România. Știu că majoritatea medicamentelor sunt folosite, dar bineînțeles trebuie să individualizăm tratamentele pentru ceea ce este aprobat în codul românesc sau european. Despre ce v-am discutat? Cum să îmbunătățim outcomes pentru pacienții cu boala incurabilă de mCRPC, castration-resistant prostate cancer, metastatic, în cursul curent în care multe medicamente apar, devin disponibile și acum trebuie să le și secvențializăm. Vom discuta despre statul curent, unde avem multe opțiuni. Vom vorbi despre doublets ori triplets, dacă este mai mult, e mai bine. Și pe aceea vom încerca să discutăm, să atingem optimizarea selecției prin teste biologice, prin biomarkers. Ne focalizăm pe opțiunile care le avem. Pentru orientarea tuturor în această boală, de la diagnosticul de cancer de prostată, unde în America au fost diagnosticați 240.000 de pacienți în anul trecut, boala este localizată, atunci poate fi vindecată prin chirurgie sau radiații, dar recurența biochimică sau în boală metastatică, prima linie de tratament este depleția de androgen depletion or blockade. Am folosit bicalutamida mai de mult, vom discuta despre aceea dacă mai avem timp. Dar în castration resistant, 30.000 de oameni au murit anul trecut de boala de cancer de prostată, boala metastatică, deși avem o mulțime de tratamente. Taxanes, docetaxel, Cabazitaxel, abiraterone, enzalutamida, sipilocel-T, radium, alpha-radin, or lutetium-177 Pluvicto, PARP inhibitors cu olaparib, rucaparib, niraparib și imunoterapie prin pembrolizumab. Dar aceste tratamente folosite în ultima linie, în mCRPC, probabil și de multe ori sunt mai eficace în linii inițiale, în boala metastatică sensitivă la castrare, unde am mutat docetaxel, abiraterona, enzalutamidele sau lutamidele, chiar și în boala nemetastatică, pe imagistica curentă, unde apalutamida, enzalutamida și darolutamida au fost aprobate și încercăm să continuăm să îmbunătățim outcome-ul, mutându-le chiar în linie inițială, numai la biochemical recurrence, fără linii metastatice. Și trebuie să discutăm și de tratamentul inițial, îmbunătățirea curability of the disease in the clinical localized disease. Okay, let's talk about what's prolonging life. Ce îmbunătățește outcome-ul. Overall survival aici. Deci discutăm de liniile care sunt aprobate pe overall survival. Avem taxanes, docetaxel, cabazitaxel. Avem androgen receptor signaling inhibitors, like abiraterone and enzalutamida. Vorbim despre mCRPC here. Imunoterapia, Sipuleucel-T, Provenge, imunoterapie, un vaccin, dar practic nu mai prelungește viața și este foarte complicat de planificat sau de dat în boala metastatică pentru că nu schimbă PSA-ul sau nu reduce tumor burden. Pembrolizumabul în cancerul hipermutat. Bone-directed therapy, radium-223 or afaredin has been approved also for overall survival in mCRPC. Radiopharmaceuticals, the newest kid on the block, Pluvicto, a fost aprobat pe baza Vision Trial. Overall survival și îmbunătățirea progression-free survival. So that's a great addition. Și avem PARP inhibitors, olaparib, rucaparib, niraparib, as single agent sau în combinație cu un androgen receptor single inhibitor. Vom discuta despre aceste tratamente secvențial. Bun, deci metastatic castration-resistant prostate cancer este cancer care progresează cu metastaze cu un nivel de testosteron care este în domeniul castrării, sub 50 de nanograme pe decilitru. Primul tratament, docetaxel, la 3 săptămâni, cu overall survival based on tax 3 to 7. That was the first treatment, 2004, that was approved in mCRPC. După aceea, Tropic Trial a demonstrat Cabazitaxel la 3 săptămâni îmbunătățește overall survival cu încă 2,4 luni. Hazard ratio is the important one. Deci, gândiți-vă întotdeauna la hazard ratio de 0,7, deci 30% îmbunătățirea overall survival pentru fiecare pacient. După aceea am avut abiraterona, avem abiraterona pe baza Cougar A301, significant overall survival improvement, right? 0.74, so 25% improvement in overall survival. This is post-docetaxel first. După aceea a venit enzalutamida în studiul AFFIRM. Acum avem o problemă sau o opțiune. Când cancerul a progresat pe o singură linie de editing, deci când a progresat numai pe luprolide sau diferelin, chiar dacă am dat docetaxel înainte sau în timpul sau n-am dat docetaxel în prima linie, avem abiraterona, deci avem opțiunea de a folosi abiraterona pe baza Cougar A302. Enzalutamida pe Prevail este aprobată când cancerul progresează din CSPC în CRPC numai pe un GnRH antagonist. You have to remember the bone targeting agents, bisphosphonates, Zometa sau Xgeva și Prolia, rank ligand inhibitors pentru CRPC. Folosesc numai în CRPC pentru metastasis, bone metastasis în CRPC. Nu folosesc în CSPC pentru că nu este demonstrat că ajută decât pentru osteoporoză, osteopenia. Then we have now novel lines of therapy. Dacă au progresat pe un doublet cu enzalutamida, abiraterona sau darolutamida în CSPC, deci acum au venit în CRPC, au devenit CRPC, progresând pe enzalutamida sau abiraterona. Este altă linie de terapie atunci. Avem Sipuleucel-T, Provenge, based on impact trial. Again, great survival benefit, but there is no change in PSA, there is no tumor burden, nu vedem radiographic. Radium-223, Alsimca trial, also improved overall survival, but that's only for mCRPC with only bone metastasis. Radium-223 will not touch the soft tissue disease, so we have a problem. Also, if you use Sipuleucel-T Provenge, you shouldn't follow it closely with chemotherapy, so that's a restriction. And a lot of these treatments use also prednisone for abiraterone to balance the cortisol suppression, and docetaxel, cabazitaxel have been approved only with prednisone twice daily. So it's hard to use Sipuleucel-T if you are to start a steroid after that. Then we have pembrolizumab approved as a blanket approval for all solid tumors with MSI high or high tumor burden in mutations, but that's very rare for prostate cancer. It's probably about 2-3%, and only half of those patients. So it's very niche kind of treatment here. And I think that's very important. What's advancing the field significantly is mutation status or genetics, really looking for targeted therapies, specifically for BRCA2, which is the most prevalent, and then maybe BRCA1 and some BRCA-like mutations. Then we have the treatments with PARP inhibitors, with olaparib, based on the trial to PARP. And if the patients progress on a single agent, so they come in CRPC with a BRCA2 mutation, only on GNRH suppression, then we have the doublets of abiraterone plus olaparib or enzalutamide plus talazoparib. And the new addition, the newest kid on the block is Vision trial with PSMA lutetium, with significant overall survival improvement and progression-free survival. Right now is approved only post-chemotherapy. We're working on pre-chemotherapy, and even in addition with the first doublet with in CRPC. So let's talk about a little bit about how to refine what's better. Should we use cabazitaxel for everyone, or is cabazitaxel better than docetaxel? So we have the Prostată trial that randomized patients to either receive cabazitaxel 20 or cabazitaxel 25, compared to docetaxel plus prednisone, the old way. And with the primary overall survival, and it was power for overall survival benefit. However, the trial showed that all three treatments are the same. So docetaxel, cabazitaxel 20 or 25 have the same overall survival. You cannot see a difference even if you try to. So basically, cabazitaxel is as good as cabazitaxel. Cabazitaxel 20 is as good as cabazitaxel 25, and docetaxel is actually the same. There is a little bit of difference in safety profile. If you look at fever and neutropenia, cabazitaxel 25 had more fever and neutropenia and neutropenic infections, so I don't use cabazitaxel 25 anymore. And in terms of neuropathy, you see that cabazitaxel has less neuropathy than docetaxel. So if I had a patient with diabetic neuropathy, with bad neuropathy, then I think cabazitaxel may be an option. But otherwise, I think docetaxel is best in the first line, not only from standpoint of cost, but also you have another option post docetaxel to do cabazitaxel. All right, is it better to use cabazitaxel or switch from enza to abiraterone or from abiraterone to enzalutamide after docetaxel? So the CARD trial randomized patients to either receive, so when they progressed to CRPC, less than 12 months, so a short course of first-line abiraterone or enzalutamide, they randomized to cabazitaxel or to the other ARSI. If they're on enza, they got abiraterone. If they're on abiraterone, they got enzalutamide, with a primary endpoint of progression-free survival. Key endpoints overall survival, progression-free. So this will tell you, should you use cabazitaxel after docetaxel, or should you go still with another hormone? So basically, the randomization worked that you'll switch from one enzalutamide to the abiraterone and the other way around. And then they demonstrated that cabazitaxel is better than an ARSI. So cabazitaxel has a ratio of 0.54. So if the patient progressed very quickly on the first ARSI and they got docetaxel, I would prefer cabazitaxel than the other ARSI for these patients. Key secondary endpoint also was impressive with an overall survival for 0.64 with a significant p-value. So that's impressive. However, you should ask how many patients received cabazitaxel if they switch to the other ARSI. And you see that only 33%, so only 1 in 3 patients received the life-prolonging therapy after switching to the control arm. So that's a critique for this trial, because at the time, cabazitaxel was not available in the countries where this was tried. And basically, you are withholding a life-prolonging treatment, cabazitaxel, on a post-trial basis, and then you demonstrate overall survival, so I don't think it's fair. But so far, for treatment options, I would sequence, let's say, abiraterone, short course, docetaxel, cabazitaxel, and then enzalutamide if you wish, if you don't have anything else. So I think in terms of chemotherapy, dosi versus cabazitaxel, first line, they have the same overall and progression-free survival. Toxicity profile is a little bit different, but economic toxicity is prohibitive everywhere, including in New York. So that's not an easy price tag to swallow. Cabazitaxel, the optimal treatment dose for me is 20 milligrams per square meter in first or second lines. And then cabazitaxel is superior to an RSI if initial RSI response was less than a year. All right, let's talk about PARP inhibitors a little bit, because we have this recommendation for PARP inhibitors in BRCA-like mutated patients. I'm not sure if this is yet approved, dacă este aprobat deja de Comunitatea Europeană sau în România, dar sper că în curând va fi aprobată. In trial to PARP, patients were included if they had mutations in the DNA repair mechanism. Most frequently was BRCA2 mutation, rarely BRCA1, ATM mutations, CDK12 and PALB2, and a slew of other ones, including the FANCA proteins, FANCA genes, and RAD52. And when they receive the PARP inhibitor, you see the PSA decline, PSA 50 or 50% PSA decline from baseline, resist responses. But if you look at the type of tumor that responded, you'll see that most of it is in red, BRCA2 and BRCA1. ATMs in blue are very poorly responsive, or CDK12s very poor responsive. You see some PALB green in the right, in the good PSA declines and radiographic progression. So I think that's very important to think about this and make sure that you personalize the treatment recommendation based on the type of mutation, not only if they're DNA repair defective. All right, so in the Profound trial, they randomized to receive either olaparib or best standard of care at the time. And they split the patients in cohort A, the best cohort with BRCA2, BRCA1, and ATM mutations, and in cohort B, all the other alterations, and primary endpoint of progression-free survival. And they've demonstrated that in cohort A, we had a significant progression-free survival benefit, right? Hazard ratio 0.34. And that's important to remember, right? BRCA2, BRCA1, and ATM. Well, I just told you that ATM is not that likely to respond. And when they look at subset analysis, so this is not power for any difference, but when they look how they benefited from either standard of care in red or olaparib, you see that actually BRCA2 was the most impressive. ATMs actually have very little with no difference. The hazard ratio is 0.93 over both sides of 1. Interesting, BRCA1 here had a poor performance, but ATM check 2 do not respond to a PARP inhibitor. However, the RAD54, the RAD52, and PALB2 are great responders, in my opinion. Next, PARP inhibitor before or after taxane. This is again a subset analysis, but they looked if the patients received before docetaxel or not, and they just focused on the BRCA2 and BRCA1. And if you look at no prior taxanes, no prior docetaxel, actually the response was much more impressive, a hazard ratio of 0.3 versus a hazard ratio of 0.64 covering 1, non-significant if they had prior taxane. So that tells me that if I was to use a PARP inhibitor, probably I should do it before chemotherapy, especially if it's a BRCA2 mutation or BRCA1 or PALB2, much rare. Dar dacă n-am altă opțiune, atunci aș folosi PARP inhibitor după docetaxel, pentru că am level 1 FDA-approved line of therapy. So, and actually it may offer some progression-free difference, but very, very rarely, and probably is not a cost-effective treatment. So again, going to refining treatment decisions. Olaparib is approved in multiple DDR mutations, but I use it only in the BRCA2-1 mutations, RAD51, PALB2, RAD54, and I would use it before taxanes, and I would not use it at all, or maybe just after taxanes for ATM check 2 CDK12. We need to improve on this, and we have some great leads on clinical trials for ATMs and TR mutations, but this is not a treatment I'll offer for patients with ATMs. Talazoparib, rucaparib, and niraparib are also approved in BRCA2 and BRCA1. And olaparib and talazoparib have been approved also in combination with ARSI, but only if they progress to CRPC on single-agent leuprolide or GnRH suppression. It's a bit complicated, but my suggestion, use olaparib, pre-chemotherapy for BRCA2 and PALB2, not for the other ones, basically. Let's talk about VISION trial. I think this is ESMO of 2023. Should use it before chemotherapy. I think this is an important trial because basically you're sequencing Pluvicto now relating to PSMA lutetium 177. You're sequencing it post-chemotherapy, so less patients are likely to get there, and then the patients are already burned out and they have a lot of marrow suppression, so probably less effective also. So in this trial, we thought about using lutetium before chemotherapy. So they had to progress on ADT, so confirmed progression on CRPC. They had to be eligible based on a PSMA PET, that all lesions were avid for lutetium, for PSMA lutetium, for Pluvicto. And they had to progress on a prior ARSI, or basically on enza or abiraterone. And they were not supposed to have received docetaxel in CRPC. They're allowed to receive docetaxel in charted in early disease, but this is not what we're talking about here. And they're not candidates for PARP, so they didn't have a BRCA2 mutation or alike. So they either received lutetium or the other ARSI. If they received enzalutamide, they would get abiraterone. If they received abiraterone, they would get enzalutamide. The best part of this is that the trial allowed for crossover. So at progression, if you didn't get lutetium, you will get it afterwards, which is great for the patients, but actually we'll see. So overall survival in taxane naive, you see that lutetium improves progression-free survival here significantly, right, by 6 months or so. So if you receive lutetium compared to another ARSI, so if you progress on enzalutamide, it's very unlikely to respond to enzalutamide. So this is a significant improvement in progression-free survival. However, the overall survival was not that impressive, and mostly because of the crossover, right? So 84%, 85% of the patients now received lutetium anyways. And if you do that before or after the switch, then you see actually that the benefit washes out. And that's interesting because we wish that actually we'll see a difference. That's how the drug will get approved. But we didn't see that, so we just have to yet follow through, or the trial is still being followed for overall survival. So they're still trying to mature the data and get that difference to get the approval. So right now we don't have an approval because the hazard ratio crosses 1. We don't have an approval in chemo-naive pre-chemotherapy to use the lutetium. So I'm still using it only post-docetaxel and maybe post-cabazitaxel. But interesting part actually that there are some patients that got a benefit from the switch from abiraterone to enzalutamide. That's interesting, right? Because if you think about the response to an ARSI after the other one, where the androgen receptor is supposed to be bypassed by the mechanism of resistance, you see that abiraterone versus enzalutamide, these are serial patients that receive both, and there are some that respond better to abiraterone and not to enzalutamide, some that respond both to abiraterone and enzalutamide, and some that respond to enzalutamide but not to abiraterone, and some patients that never respond to either abi or enza. So that's the unknown. Who would be that patient that should get abiraterone and then enzalutamide and then docetaxel, cabazitaxel, and then lutetium? We still have to understand that part. Personally, I don't think there's a difference between which one to use first, abiraterone and enzalutamide, but I'd like to review this paper in urology in 2015, that the patients that received first abiraterone are more likely to respond to the second line of enzalutamide versus if you use enza first. But I think this is a very small paper, and this doesn't have any real bearing in the clinical life. All right, so we talked about the many choices. Are doublets better than triplets, or the other way around? Let's talk about a little bit about that. So what I'm going to present is the data on should we continue, should we use both enza and abiraterone in CRPC? Is that a benefit of synergism of lowering testosterone further, even in the tumor cells or fat tissue or adrenal glands with abiraterone, and then block whatever else is left there with enzalutamide with AR blockade? So the trial, the CLJB 031201, this cooperative trial, randomized patients to receive either enzalutamide or enzalutamide plus abiraterone. This trial was actually led by one of my colleagues here at Memorial Sloan Kettering. However, there was no difference. So adding 2 drugs at once, 3 drugs if you think about GnRH, is not better than 1, but there's more financial toxicity and actually metabolic toxicity and liver damage and other things. So I will not combine both. I'll use first enzalutamide or abiraterone and then switch over later after taxanes, basically. Should we continue enzalutamide at progression when we add docetaxel? So the PRESIDE trial randomized patients that progressed on enzalutamide to either continue enzalutamide and add docetaxel or just switch over, so placebo, and then receive docetaxel. And lo and behold, the hazard ratio was slightly significant, but I think the difference is very small, and we don't use this. This progression-free survival and overall survival was not significant. So basically, in my practice, I will stop enzalutamide and I'll switch to docetaxel. I will not continue the ARSI that progressed on. Is there synergism between a PARP inhibitor and ARSI? I think this is the idea of if an ARSI, so augmenting the androgen receptor suppression with an ARSI, will damage the tumor cells, and then using a PARP inhibitor in inhibiting that DNA repair mechanism, would that offer a benefit? And the PROPEL trial randomized patients with a primary endpoint of overall survival. So progressing on CRPC on ADT, adding olaparib didn't change much. And this is in all comers. However, if you look at magnitude trial, where they use an ARSI and a PARP inhibitor for BRCA2 and BRCA1, actually there was a progression-free survival. And FDA approved this combination for these mutations, but only if they progress on the ADT alone. So remember that first slide, când aveam opțiunea pentru CRPC on single agent ADT. If you're having a BRCA2 mutation, then start abiraterone with olaparib or niraparib, or start enzalutamide with talazoparib. Dar în acea combinație ne așteptăm la un răspuns de 3 ani, 3-4 ani și dai un PARP inhibitor in addition to enzalutamide or abiraterone. And anyways, if the patients were metastatic in the first line, you should have used an ARSI long ago. So that patient population is very, very small. And this is not applicable to mCRPC progressing on ARSI. So very small patient population. Let's quickly go through optimizing selection or biomarker. Testing biology is selecting better choices. So we have the androgen receptor pathway. We're inhibiting the AR translocation or inhibiting the DNA binding sites will offer overall survival. However, AR splice variants where the DNA binding is considerably active because the ligand binding is not present anymore, or alternative pathways such as PI3 kinase, mTOR, SRC, or c-Met activations will bypass the AR or work through AR, but will not actually respond to an ARSI. These are alternative pathways that we should focus on to try to improve to get better treatments. And we have a very strong multi-institutional genomic profiling effort. The initial report demonstrated androgen receptor pathway alterations were present in 71%. Most of this is androgen receptor amplifications or mutations, truncating mutations. PI3 kinase seems to be significantly altered, and the P10 deletion is a very prognostic marker for that. But the big hit was DNA repair defects, where BRCA2, BRCA1, we already talked about part of that. How is the distribution of these mutations in the local regional or evolution of this mutation across the states of prostate cancer? You see that in local regional, most of them are prognostic P10 and P53 deletions, which are more aggressive tumors, and that's probably this patient's got sequence. But as you advance to the disease, androgen receptor amplification becomes more significant, and then DNA repair seems to be, DNA repair defects seem to be about the same, maybe a little bit more frequent in metastatic castration-resistant disease. If we're to focus on mutations with impact, with clinical impact, actually BRCA2 is the most prevalent. BRCA1 is quite rare, ATM 5 to 10%, and then the other ones are maybe CDK12 is about 10% in current studies. Germline versus somatic plus germline, I think this is an important concept because germline mutations, the patients who are born with these mutations, will affect not only the patient, but also their families. So knowing about the BRCA2 mutations, for example, will inform their daughters and their sons and their grandkids and nephews and nieces for risk for prostate cancer, ovarian, breast, colon, and other cancers. So it's very important to recommend and look at that. So if you think about BRCA2, it's quite frequent, about 10% in germlines. And if you look, germline and somatic is about 15 to 20%, depends on patient population. That's the most frequent. I think we should offer this to all patients with metastatic disease and initial patients. All patients that are diagnosed with high-risk prostate cancer should get genetic testing, should get actually discuss this potential for affecting their treatment options, their screening for other options, for other cancers, and actually informing their family of gene carrier of a significant mutation. And I do that in clinical practice all the time. It's time consuming because you have to counsel the patients, but I think it's very important and it's very informative. I think știu sigur că este posibil și în România. Este complicat pentru că trebuie să-i informezi pe pacienți și trebuie să-i counsel pe pacienți și familia lor, ceea ce devine time consuming, dar de asta facem, de asta suntem în medicină, să ajutăm pacienții și să ajutăm să se simtă mai bine. Another hot topic in prostate cancer is androgen receptor mutations or truncating mutations. If you follow the field, it was holding great promise, and we'll talk about what's the impact in clinical practice. Despre ce vorbim? Deci, androgen receptor, full-length N-terminal DNA binding domain, and then a hinge, and then a C-terminal ligand binding domain, where testosterone goes in and activates the receptor. The receptor is considerably inactive. You need testosterone to activate for it to dimerize and translocate to the nucleus and activate. So if you truncate that red part, that C-terminal ligand by testosterone binding domain, then you'll have a N-terminus androgen receptor in truncated form that will be active, independent of testosterone. Actually, you cannot even inhibit the androgen receptor blockade because there is no DNA, there is no C-terminus, there is no ligand binding domain, there is no testosterone binding, so there is no place for enzalutamide to go in. The most frequent is androgen receptor V7 splice variant, first presented or clinical impact presented in 2014, but there are many others. The most prevalent is ARV7, and we'll talk about that a little bit. There are other point mutations that inactivate the ligand binding domain, so the N-terminal domain and the DNA binding domain become active. So inactivating the C part, C-terminal will activate the androgen receptor. And those are known mutations like the flutamide mutation, the A75 or A74 mutation, where you give flutamide and you paradoxically activate the androgen receptor, is the famous one presented in 1999. But then we also have similar for enzalutamide and apalutamide, the 877, and the abiraterone seems to be considerably active. And there is another one, 878. There are other mutations that will make an anti-androgen an agonist instead of an antagonist, but those are rare. So how can you look for this androgen receptor splice variant? It's very hard to do a biopsy in prostate cancer, but we can isolate circulating tumor cells. We can draw a blood sample and then look for tumor cells that have characteristics of the primary metastasis, right? The tumor, the metastasis will shed the CTCs in the bloodstream that we can isolate very well. And I'm going to talk about the EPIC platform, where the blood sample is the erythrocytes are lysed, and then all the other cells are displayed on the slide, and a very good imaging system will analyze each cell for their specific phenotypes. Here we use the CK, cytokeratin, and CD45, DAPI for nucleus, and then you have another channel. And you scan all cells, and you can create this biomarker analysis or CTC identification chart that will give you multiple parameters. And we develop an ARV7 staining, so a stain specific for that truncated androgen receptor that doesn't have the C-terminal, but has the N-terminal. And then there is a little bit of a splice variant that has a specific amino acid sequence here that you can create an antibody and look at that. So we define an EPIC CDC biomarker where if you had the androgen receptor V7, that test was called positive. And what was the implication of that? So I told you that if you have a truncated AR, then you are not likely to respond to AR targeted therapy. So we first look at what's the prevalence of this AR. So here on the left side, you see in orange ARV7 positive patients in first line, meaning CRPC coming after androgen receptor blockade, GnRH suppression with differalin or leuprolide. Second line and third line at the end. And you see the prevalence of this is very rare in first line and is more frequent in second and third line. And the response, the PSA decline, so you have there each bar represents a patient. You have the waterfall plots for first line, second line, and third line patients, and in orange, the ARV7 positive. So you see the ARV7 never crossed the 50% or less. Didn't have a great PSA decline. So basically, if you had the ARV7 mutation, truncation, you're unlikely to drop PSA by 50% or more. But when you look at that, the chance of that to happen in first line is very rare. And in third line, well, you don't have many more options after that. So the clinical value of that is still to be defined. Yes, if you have ARV7, you're more likely to respond to a taxane. So in theory, you can switch. Instead of giving abiraterone, you can give docetaxel. But I'm talking about third line, where you already used the docetaxel and cabazitaxel. So you don't have much left there. So you might still try, or I will still try the other ARSI, even if the patient had a ARV7. So then I don't need a test. I don't need to send a test because actually there's not much of a clinical benefit. There's not much impact on the patients. But yes, it's a prognostic biomarker. If you have an ARV7, the tumor is more likely to be a bad prognostic, right? Will patients die faster? You see that on the right side, the overall survival hazard ratios, 11 times more likely that you will die faster if you have an ARV7 compared to a negative V7. And also the taxane treatment, yes, you should, but you know that clinically, right? The patient responded very shortly to a first ARSI, and then you have to use a second taxane, not the other ARSI anyways, based on the CARD trial that we just discussed. So I think this is little value in clinic. So long story short, but I think we have a lot of options. We have to sequence them correctly. And we have to improve our ways that we select patients, the right patient for the right treatment, and not run into toxicity unnecessarily when the patient is not responding. We shouldn't stay long on the same treatment. We should just avoid that and try to be proactive in how we treat patients based on the biomarkers. So in my practice, when the patients progress on castrate levels of testosterone, if they present on a doublet, if they come in progressing on ADT, be that differylline or leuprolide, with enzalutamide, abiraterone, or docetaxel, or darolutamide, even if they had prior docetaxel, if they don't have a mutation, I'll use, so if they progress on enzalutamide, I'll use docetaxel, cabazitaxel, and then Pluvicto, PSMA lutetium, then abiraterone, and maybe pembrolizumab if they're MSI high or TMB, high tumor mutation burden. If they have a mutation and they progress on a combo, if they progress on Enza or Abi, I will stop the Enza or Abi and I will switch to olaparib. If they had a BRCA2, BRCA1, or PALB, I will not use a PARP, basically, if they had an ATM or CHEK2. So Enza, switch to olaparib, docetaxel, cabazitaxel, Pluvicto, abiraterone, and MSI high. If they progress on, if somehow the patient was metastatic and you studied them only on ADT and didn't use a combo, which is rare or unlikely because the patient should be on combo from the CSPC, from the early disease, but they had a mutation, then yes, I would recommend to consider a doublet abiraterone olaparib or enzalutamide talazoparib. However, these trials did not have a comparator for abiraterone first and then olaparib or enzalutamide first, but there's a label there for the combo. But personally, I'll probably use enzalutamide and then use the olaparib, dosi, cabazi, Pluvicto, that. And then think about CP-LUC-LT, where to use it, and let me know. And radium-223 actually is very hard to sequence also. We have a trial right now where we try to combine radium with docetaxel. Seems to be not too toxic to use radium first and then Pluvicto later, so there's not going to be a likely extra toxicity by using two radiopharmaceuticals, but I'm not sure about the benefit. The trial is still accruing, is still ongoing, so that's yet to be defined. And then don't forget about skeletal-related events, fractures and pain. You can prevent them. We should prevent them actively with calcium, vitamin D, exercise, and I personally use bisphosphonates, zoledronic acid, because in our group here, we had a lot of severe, significant hypocalcemia with RAG ligand inhibitors like denosumab. And we decided not to use it. The benefit is limited, and the chance of phosphate necrosis of the jaw is higher with the RANK ligand inhibitor. But yes, there is a label for improved delay in skeletal-related events with denosumab. But personally, I use zoledronic acid. So I'd like to leave you with the idea that the continuum of prostate cancer has evolved. The treatment options have evolved significantly. And we are still improving the way we use these drugs and what drugs we're bringing to the clinic. We have many options: taxanes, ARSIs, Sipuleucel, alpha-radin, and Pluvicto, PARP inhibitors, and pembrolizumab. I think trying to move them earlier is an active effort, and we've demonstrated significant benefit in moving docetaxel early on, but now we have even better options with Enza, APA, and Daro, and abiraterone is out there. And yes, we are moving these in earlier disease. We haven't discussed much about PSMA imaging, the gallium-68 or the Pylarify. Those are new. They are redefining the disease, but that's where we have to try to improve the outcomes by moving early and trying to avoid this deadly metastatic castration-resistant disease. In real life, I think choosing the right next line depends on the prior treatments. Tumor biology is very important. Type of metastasis, we can discuss about bone metastasis versus lymph nodes versus visceral, liver, lung. Comorbidities and symptoms are very important that will really force your hand to use a more aggressive treatment in high burden and symptomatic patients. Of course, approval status and formulary or availability, insurance, are very important, and it's hard to fight it or hard to find it, but ideally we should have access to all these, patients should have access to all these drugs. Consider focal therapy or SBRT, stereotactic body radiation, to oligometastatic disease. Basically, if they progress on a single focus, let's say a single bone metastasis that's growing, that's enlarging, maybe you want to keep the same enzalutamide and radiate that lesion if you could. And my pet peeve or my joke is that if you don't know the answer, clinical trials are always the best answer. I think participating in clinical trials have a lot of benefit to patients in totus, but also in our understanding of the biology and how to treat this disease better and with less toxicity. Take-home messages, cu ce aș vrea să vă las. Avem o mulțime de tratamente, dar toate liniile de terapie vor fi terminate la un dat. We have finite lines of therapy that eventually have to admit that this disease can progress despite all efforts. Wait for true progression before changing therapy. Try to use the therapy you are on now for the longest. Try to use the silver bullet for the longest it works, because we have only very few excellent but limited silver bullets. Docetaxel, I believe, is still an active drug. I still use it in day-to-day clinic, and I think it's still very, very helpful, very useful. And where we are advancing significantly is molecular profiling to select therapies, sequence germline and somatic mutations early, basically in all metastatic patients, and in early high-risk patients that you know they're going to recur, you know they're going to have bad disease, and actually you might help their families, you may help their daughters even to IVF acum are o opțiune de a selecta pentru ovulul care, fecundat care să nu aibă această mutație. Deci sunt implicații în multe linii. I offer it to everyone, and some patients decline because the information is powerful but scary. But actually for the patient himself, actually, there is a line of therapy that will be added, and we may actually improve the outcomes. We may learn better on how to sequence the disease, and maybe a clinical trial that will help along in figuring out how to do better. I know it's been a sprint through all these options and all the treatment options that we have available at this point. I'd like to extend my thanks. Să mulțumesc organizatorilor și că m-ați invitat. Aici lucrez, aici practic locuiesc. chemo building in Manhattan on 68th Street and First. Dacă sunteți în zona, aștept să-mi dați un telefon, să mă contactați și mi-ar făcea plăcere să ne vedem și să discutăm. Sunt încă legat de țară și îmi place foarte mult să vin în București și vorbeam cu profesor Croitorul că o să ajung și în Delta în curând, dar aș bucura să văd la conferințe sau oricând avem ocazia. Dacă aveți întrebări sau mulțumesc foarte mult pentru invitație.
Noi mulțumim pentru prezentare. Vreau să vă spun că ați fost urmărit de 100 de participanți, 101 participanți.
Mulțumesc frumos!
Da. Și nu numai atâta, sigur că mulți vor accesa și, dacă ne permiteți, lucrarea înregistrată de pe site-ul nostru. Atunci, sigur, vor mai fi și alții care n-au putut să se logheze astăzi și vor putea să acceseze. Vreau să vă întreb, mulțumesc, deci aveți lucrurile atât de clare și așa de ușor le prezentați și așa de pe înțelesul tuturor, chiar e grozav. Experiența clinică spune cuvântul oricând, deci e clar. Felicitări. Încă o dată, mulțumiri. Vă aștept.
Cu mare plăcere și sper să ne vedem în curând.
Da, și eu, la fel. Mulțumim și succes.
O vară plăcută, numai bine.
Vă mulțumesc.
Sănătate.
Mulțumim, domnule profesor.
Și eu vă mulțumesc foarte mult.